cheap.
Storage.
Fat is a storage of energy.
Short chain fatty acids.
So it has been found. Brandon, what is the normal substrate for the majority of the body? Providing energy. Huh?
Carbohydrate.
Huh?
It's carbohydrates.
What do you say?
Carbohydrates.
Yes, glucose.
Yes.
So in the epithelium of the colon, it has been found that the main substrate is not expected to be carbohydrate, glucose. Yes, you understand, sir? You understand? It has been found to be short-chain fatty acids. And the bacteria that are in the colon, there are plenty of bacteria in the colon, they break down all that fecal residue, whatever fat that wasn't digested, etc., and convert them into short-chain fatty acids. Yeah? Butyric acid compounds and acetic acid compounds. Yeah? So that's my theory is that diabetes is like half of that money. Yes, you can get your stuff, sir.
Just relax.
Relax. Okay, so you understand that? Now, the colon, the ascending colon extends from the cecal, which is the thinnest part of the colon, and it ascends to about the hepatic flexure of the colon up here, the hepatic near the liver. It's usually related to the mid-axillary line. The colon 9. And the splenic flexure is 2 ribs higher. So that's 7 to 8, all right? So the only parts of the colon that are on a mesentery that we can lift up is the transverse and the sigmoid. I can lift up this ascending colon, but it's normally impossible to do that because the peritoneum that's carrying the blood vessels, all the mesocolon, yes, they cover the ascending colon on its inside portion there. It's anterior and it's reflected laterally onto the side wall of the pelvis. Yeah? And at the line of reflection, when you attempt to lift up the colon like that, it will pull up on that peritoneum and will give rise to what? You can't show it. Everything in the body here looks wrong. But in real life it looks white. A white line.
Of toes.
You should remember the name, white line of toad. So like a person should have a cancer in this ascending colon, and we need to resect it, we have to mobilize the colon. And the first thing we have to do is incise the white line of toad. And when we do that, we can gently separate the mesocolon and just lift up the colon like that, so we can resect it. Eh? You follow?
Sir, is that what they call cauterization?
No, nothing.
Or that's not
They're too fast. The young guys are faster than that. So what keeps the splenic flexure in its normal position was what ligament again? What keeps the splenic flexure of the colon in its normal position? What structure again? We talked about it. The phrenicochoric ligament, yeah? So would you expect on the right side something to keep up the hepatic flexure? Yes. And you won't know yet, you know? But I think they cut up these specimens because I would have divided, lifted out, shown. There's a ligament from the liver to the colon, the hepatochoric ligament, and another from the duodenum, called the duodenum-choric ligaments. And you have to incise these two to finally mobilize the ascending and the hepatic flexure of the colon. Eh? So when we mobilize the colon now, we can move either the right colon to this side, and similarly the other side, the left side, to the other side. And when we lift that up, pull it to the left, we can see a structure here. I My friend in the line, sure, you're gonna learn too much today. What is the structure? That's why you must love to come to these things. You know? Cameraman, you have to come in. I got you from the bottom. Impossible. Never could have never can. Huh? Are you seeing that, brother? Good, just to get a little orientation, helping you, I'm helping you. I try to help that's what the creators said easier for them, to help save the sinners like me and you.
Right. Real spill.
Yeah. He says those who are whole doesn't need him, you know, basically, don't it? So I'm trying to help you, the weaker ones.
Oh, okay.
This is the stomach, brother, you see? Yeah.
Yeah.
Don't think that I'm pressured.
Interesting,
I don't want you to see it. This is the stomach, going all the way back to there. You see this stomach?
Yeah.
Right.
You see this stomach, big stomach. You see this thick portion here, right? You see this thick portion, brother? This is the pylorus, the sphincter.
Could we maybe move the camera closer and point it down?
And with a little imagination, this is some darkish thing running on the top of it. With little imagination.
Wait, is there any way that we could move the camera closer and then point it
That's
down?
why I'm asking them today. You bring the camera closer and
No, as in not zoom in, but bring the whole thing like
that's why I'm
closer.
saying to bring the camera nearer.
Yeah.
Physically.
Are you guys
No,
I told the gentleman to rotate and move that tripod stand which is walking on the table, bring it inside here so they can come close. Understand? No, pull it back first. And so that foot can come inside here.
It's actually fine like that.
Pull the tripod towards you. You don't move from back, come back.
Dominic, what was that message I just saw, Dominic?
Right, pull it through so
Dominic, who's side chick 5, Dominic?
coming close. Now you can focus on the pylorus.
See, he not even denying it though.
Next thing you know.
Is that a bee sting,
You're
Dominic?
gonna show up with a bee sting, bro.
At about
I don't know,
this
you
point,
laughing.
I get the impression that there could be some vessels there, don't it?
Definitely, if you
And madam, what those vessels would be in real life, huh?
You're referring to the vein of Mayo.
Right. The prepylor vein of male. Right? So that's what it is. And that really leads into this structure now, which my lamb sure guys has said was the duodenum, yeah? This is the second part of the duodenum. Right? And the peritoneum is reflected off from its anterior surface and it's going laterally to partake in the hepatorenal pouch. Yeah? So to mobilize the colon, this is duodenum, what we have to do is incise the peritoneum as it's reflected laterally from the duodenum. You follow me? Incise that peritoneum. Yes? And this process of incising the peritoneum from the second part of the duodenum as it's going to the right lateral is called cauterization of the duodenum. Cauterization of the duodenum. And that's an important thing to remember because remember we showed you the major duodenal papilla, yeah, where the bile duct is coming down, and sometimes stones are impacted there. We usually try less invasive methods first. So we'll ask the gastroenterologist, the endoscopic patient, and try and fiddle around and see if they can divide the sphincter for the stone to fall out. And if it works, and that would be good. But failing that, then we have to come to open surgery. So you have to make incision in the anterior abdominal wall, divide the white line of tool to mobilize the right colon, the Cockles procedure. And having done that, we now can insinuate our hand like that, and lift the colon forward. I mean, not the colon, the duodenum forward. And we know where it is, about 10 centimeters from the pelvis down, distally. And we'll make a longitudinal incision into the duodenum and find the major duodenal papilla. Make an incision where the stone is, clips it out, and then we would probably just put some sutures in the cut that we have made. Okay, the sphincterotomy first. Atomy is the cut, and plast is cut and repair. Plast, sphincteroplasty. You understand me? So I wanted to show you that. But unfortunately, the guys have gone and opened the whole tummy and done what I didn't want them to do. So today, Mr. Gardner is talking about the rectum. Yes, and inner canal and Ishiorectal fossa. And I'm lifting up on the large intestine. You see that, friends? What's his name? What's your name, brother? Jordan? Yes. It's Jordan.
Yeah.
What you said?
I knew that. I said that.
She was a bit confused.
I was not confused, sir. I
Not
said
you,
it was
she was
him.
confusing me.
Yeah.
She says not Jordan. No.
It was him. It was not
Okay.
me.
So Jordan, what part of the large bowel is this? This is the appendix of the lipid bladder. Still has appendicitis. So this colon is the sigmoid colon. This is the sigmoid colon. And as the sigmoid colon continues down, the whole body around, it continues into the rectum. And where it continues into the rectum, there are no appendices diploids. You understand? There are no appendices diploids. And on the colon, there are some longitudinal bands, which are called the tinea coli. Like this one here. This is the difficult key, the fact things are, and ones are called the tinea coli. They are longitudinal bands. And they are equidistant from each other, 120 degrees, yes? And they are given names. Right, Anthony? Now the one, trying to find a decent one to show you what these specimens are helping with. Here's one that runs on the free surface of the colon. I'm not finding it to show you. Yeah, that's a betone, Anthony. Here's one that runs about the anti-mesenteric wall, which I'm trying to locate, but I can't find it. So, what you call those, that one?
I just came locked up. Are we in the cooler?
Huh?
Are we in the cooler? Or the rectal right now?
Yes, and I'm saying there are 3 tinea coli.
Oh, 3.
Yes. One that is running freely. Nothing is related to it. Yeah? I'm saying I'm having trouble locating it. Yeah? But what is that one called?
Libera?
Right, it's liberated. It's called the tinea libera. Yeah? And there's one that's running where the mesentery, the blood vessels are coming in, right there. One is running there. And what is that one called? Where the mesentery is coming in the blood vessels. The tinea is running.
Mesopolica.
Right, the mesocolica. Right, you already know the lectures I'm in here. And where's the transverse colon? They've removed the omentum, you know? Or have they? Not seen much of omentum here. But you know, the transverse first colon has omentum, yes?
Yeah.
It's not here.
And where the omentum is attached to the colon, there is another tena. And that one is called the
I don't remember the name of that one.
momentalis. So you must remember the name there.
Wait, is it? Are we going to be able to see, like, see the distinction on the specimen?
Yeah, in exam we won't put you, we won't give you a specimen. That's not showing what we're asking.
So there are specimens that you can see the distinction?
Yeah.
Okay, fine. But I can't see them.
Yeah, because when we sent in that exam, it's a whole day night thing, you know. Start from 9 o'clock and end up about 9. Mr. Gardner is even later than 9. So we have to what we call vet every question to see that it's worded properly and that the answer is on the appropriate answer is on the mark. You've seen it before. Okay, so you need to know the peritoneum. The peritoneum. You saw the sigmoid colon, which has a mesentery, so it's almost completely surrounded by peritoneum. Yes? The sigmoid now continues in the rectum. And how long is the rectum, my friend, in the rectum? How long is the rectum?
30.
Huh? You have to do it short, just like in the esophagus now. Distances are very exact in the esophagus. And I showed you the reason why. And similarly, in the rectum, the distances are crucial. When we do off with the rectum, what they call sigmoid scope, either flexible or otherwise, or rigid, we need to know the exact distances. Huh? What did Mr. Gardner tell you the length of the rectum is? Huh? Sorry? Most surgeons will say it's 12 centimeters. Some say 50. Yeah. 1.5. So between 12 and 15 centimeters. And the anal canal is how long?
4 centimeters.
Exactly 3.75, so we round it off at 4. And you see where some surgeons would want to, some teachers would want to go with the 12 rectum. Because the rectum is divided into how many parts? Nevada desert, man. Huh? Two. You went to Mr. Gardner lecture, he told that the rectum is divided into 2. Huh? Oh, you didn't manage to get it. Oh, yes, he was ill that morning.
Is it not 3?
The rectum is divided into 3 parts. Upper, middle, and lower parts. Understand? So assuming the 4 of the anal canal is nice, upper, middle, and lower, so that the total inner rectum would be what, 12 or 16. Yeah? If you use the 5, then it would be 19 to 20. You understand? So why it is so important? You need to know the peritoneal relationships of the rectum. Okay? The sigmoid is almost completely surrounded by the peritoneum. So when it reaches the rectum, yes, the Gardner will do nice specimen. The peritoneum will continue over the first part, first part of the rectum, on its front and its lateral side, but not posteriorly. Understand? So the upper third, or the first part or upper part of the rectum, has peritoneum on its front and its side, right and left side of the medial lateral side, but not posteriorly. Yes? Yes. Can you just help remove this? When you reach the middle now, the middle piece of rectum, the relationship of the peritoneum is that it comes down the one on the anterior aspect and only covers the first.
Cameraman.
Only covers the first half, the second half of the rectum, and that's only 2.5 centimeters. comes down and just comes after the first 2.5 something, is then reflected anteriorly. When we guide the male, it's reflected onto the bladder, right? And that reflection forms a pouch, rectal vesical pouch. Me and Mr. Gardner have differences of opinion. Mr. Gardner called this, he called this the rectal vesical pouch of Frost, but I don't agree with him.
Hold on, give me then quick. This I'm not sure what you're asking for. What
Yes,
is
man, is right.
I'm not too sure.
So here's the other piece. Oh, he didn't bring the other piece.
I don't know what goes on to what
This is the one of the early primitive and the alien scripture. Steve, we dial in anus, we push it up. Here's supposed to be another piece that's strong with this. We mobilize the rectal sigmoid or colon, whichever part we want to do. And mobilize the inner rectum. Push it up, and we make a little first string of the lower top part of the inner cancer around this. Yeah? And then we screw this other piece on. Yeah? And having screwed it, we push this stuff up into the proximal part, lower end of the colon or rectum. We put a person around it. Yeah? And having done that now, we approximate them as close as possible as we can, yes? We approximate them. And having done that, then we fire the blood.
the first part.
Can you see that now?
Yeah, just like that one. Bam. And it staples a complete circle now.
Then the patient is happy.
Yes,
Okay.
coming up my hand with the ostrum.
I need to come.
So these are new outcomes to prevent patients having ostoms. And sometimes when they have like the cancer at the rectum, Mr. Gardner until it's all related to the peritoneum. And that's how the length. We have to take out the whole inner rectum. Eh? And if you take out the whole inner rectum, you're not left anastomose down there, don't you? So you have to bring up the proximal end of the colon to the surface as an ostomy, and they have a bag. So that's it. They wear a bag, and the feces just goes into the bag. Yeah? Not a nice situation.
So it has there's a part missing to it, Peter, then, right?
Yeah. Remember those, I gave you a number for that.
Right, there is a box, you know, but I didn't know, yeah.
He has everything, you know.
We have everything.
He has everything, except money. He never have enough. Like we all know. See, understand? So, let's look now with sigmoidoscope. Through the inner verge, through the inner canal below. That's what, 4 centimeters, don't it? Are you with me? The first part is the rectum, that's the inferior part, the lowest part. Does it have peritoneum? No. So that's what, 4 and 4 make 8 centimeters, no peritoneum. Then the peritoneum is kind of reflected with.
On the anterior side.
At what level now? We said in the middle part, the first 2.5 centimeters. What's up? It's reflected off from that, in the middle to the bladder, in the woman to the back of the uterus, pouch of Douglas. You follow? So the level of peritoneal reflection is how much now? So we're going from 48, and then we continue another part up into the middle of the rectum, 10.5 centimeters, roll it off of 10. Now I told you that the peritoneum is what is important for the surgeon. When he resects cut that has peritoneum and joined together with peritoneum, it's not the brilliance of the surgeon, although the surgeon can do it brilliant. because of God, the Creator, that peritoneum heals within 24 hours of the surgery. Yes, all things being equal. Make airtight and watertight. You understand? Within 24 hours. So when it's air and watertight, all things being equal, you're not going to get any leakage. Yeah? So remember, this 10 centimeters is after the cutoff now. Above, if the tumor is there, we can resect the tumor and anastomose because it has some peritoneum and it will heal well. And below, general below, no peritoneum, or heal well. And the older days they do take out the whole thing. Yeah? So when they preserve the normal bowel passage, it's called an anterior section of the rectum. Yeah? Anterior section of the rectum. But when they remove everything now, the inner rectum, it's called an abdominal perineal resection of the rectum with an end colostum. And we try as best, the patient big as best as possible to avoid the colostum because you have to wear a bag and it's a bit of a nuisance, don't you can
I
imagine?
can show them a colostomy site, let me bring it and show.
Yeah, they're very thin.
Sorry.
Understand? So, with our knowledge now, with our knowledge of anatomy, we are doing much lower anastomosis to avoid this ostomy. Yeah? And I didn't highlight, I wanted to highlight it yesterday at histology, but our good friend Alicia popped up just at that time. Yeah? When you look at this small intestine with the villus, this is the lacteal vessel, which is lymphatics, no? And cancer tends to spread by the lymphatics, don't it?
Yeah.
It's running right up to the top, eh? When you look down by the rectum, Mr. Gardner didn't highlight that. Do you have any lacteals going up towards the mucosa in the rectum?
Any what?
Lacteal vessels. The answer to that is no, you didn't say no. There is a submucosa. And they are finding now, if you can detect an early cancer, early, because it's easy, okay, perhaps these instruments will look formidable to you. Up through the anus. Or even this one, which looks less formidable. And even this which looks like a weapon. Yeah.
Leave it all alone, bro.
So when you're going to do a rigid scope, these are rigid scopes. If you look, they have centimeters more marking on them. Make sure the patient knows this when you're coming in. Because they will probably just
Leave it all alone.
again. Understand? It's not forward, so they're going to push this up and be down. You know, all of us somewhat scared of it, right?
Doc, do you sedate them before you put it in? Or do you sedate them?
No.
Okay, well,
What do you mean?
no, okay, but you don't have to.
I can start.
It's not really that, but
Nah.
it's the principle.
Nah.
So I was saying, for the early cancer,
Keeping the cancer. They can sedate me, bro.
What they call that, this. This. Yeah, like this. This sector. But you have to get the cancer very, very early. Otherwise, you have to do it right. Take it out.
I think I'll go back to that.
And we're going to do an anterior resection. You must understand why we do an anterior resection versus an AP resection. And having said that, the modern trend is that we're now doing what they call sphincter saving operations. And we make lower and lower and lower anastomosis.
Excellent.
So what the colostomy.
I thought I had a specimen with that had a colostomy. Okay? fact, this is it, Patrick. No. Give a chance.
Give a chance.
Oh, we're looking down. So this is on the, which side are we looking down on?
I can't see.
Yeah. So this person had, first of all, a burst abdomen. Okay, you can see that. So after surgery, and they had sutured up, the whole thing just ruptured. Right? There was a scientific word for that, right? When ruptured.
Just a burst.
Just a burst, yes. You can see, so the whole thing had just ruptured over. Okay, so this person was really had a rough time. And they pulled out this ileum here, Patrick. You know that ileum right here.
Yeah.
So there you can see the ileum. So this is the ileostomy. Okay, so the bag would have been over on this side. Okay, on the colostomy, it would be over on the left side. So it can be on that side. And then now, we will see that it was a disaster. You can see now where the sutures were when they had done the surgery. And you can see now that there are a lot of adhesions. So this is all adhesions that we're looking at here. You see that in the neck? And there, what are we seeing there? This looks to be mainly what? What part of the gut does this seem to be when we're looking at here? You can zoom in on him high. Feel the neck, look and tell me what part of the gut, small intestine, you think we're looking at here.
You see the idea?
Yeah, I mean, I thought that.
You just see some complete circles going across there, man. That's in here.
Oh, I missed you.
That's why we have to engage your brain before the whole time.
So you will see it looks rather thick wall too. So thick wall is going to be what? Jejunum. It could look to be jejunum, okay? Thick wall. Okay?
Yes.
But then maybe getting further down to the island. So feel it anyway. What basically is this tissue here? Is this transversalis fascia or peritoneum? So the person's abdomen ruptured. Okay, it's a burst abdomen. So Gardner's asking you, what is this here? You don't go ahead, what is either?
The transversalis fascia or the peritoneum.
Right. What do you
Peritoneum.
Okay? I would think, yeah, it's very much like peritoneum. Because all the days, everything has ruptured and torn apart. Right? So this is a bad story. Yeah, so and you can see the ileostomy here, and there you can see that there are a lot of adhesion. Okay? You see that? Everything is all together. So this is double story. So feel the neck, we showed you a couple of things. So out of a cadaver, I retrieved this. Out of a cadaver, I retrieved this. Right, Patrick? But this is up at the other end.
Like the mouth?
So this is called a musu barbin tube. Right. So in the older days, not that long ago, you know, at National Chest Hospital, they would have a lot of these. So people with esophageal cancer, so the esophageal cancer, so this is like a palliative thing. But they're at the very end, you can't do anything. So this is pushed in, right, and then anchored. But many times they tell them they're just to have liquids. But Jamaicans love to have what? Yam and all kind of things like that. And in the soup, they have all this. So in all the time it's getting all what? Blocked up. So this is called a muslin barbing tube. Okay, and then the other thing we're showing you, this lovely instrument called a bomb gun.
A bomb gun.
Yeah, so what's the bomb gun? Or a sigmoidoscope. Of course, you know, when the patient is lying down and they have to say, okay, they want to examine the sigmoid colon, etc. Patient, of course, is very happy when he walks in with this, right? Where are you? Where are you going now? What I mean? All right. So as you can see, it's all graduated. Okay, it's graduated. So he knows as he's coming, as he's going in. But as you can see, this is an older kind of a British system because these are all inches. Those are inches. Right? Alright, so what is the length of the Anal canal in centimeters is what? 4. Okay, and rectum is what? 12 to 15. Right, about 5 inches. Rectum is about 5 inches, okay? So very interesting is that, and then this last voice caller, this one is still used very much. Now this is being replaced by this. However, there is a difference in that this has a light source, okay? So as you see, there's some electrical little things, and there's a thing that when he pulls it, pushes it in, all the way there, and he pulls it out. Right? Right? This is called a what? Obturator. This is called an obturator, right? So when he pulls the obturator out now, then there's a device now that he pushes in, or in fact, that he has here and a little valve here, and he now starts to inflate, insufflate, right? Insufflate, right? He'll start now to pump up, pump, like he's pumping up a bicycle tube, right? Pumping and pumping. And then now, he has now a light source. So a long thing goes in with a little bulb at the end. Tiny little bulb. And he's going to be examining as he's going on. So the first thing very interesting is how do you have to direct the instrument? So when they push it in first, it's directed towards what? The umbilicus. Right? So the instrument is going first up to the umbilicus. Then after that, we get there is a puborectal sling. So we're going to get a different direction. We're going to see how it's going to go here. So you don't have to turn the instrument in a different way to get into the rectum. And when he's going through the rectum, he's going to be encountering what? So he's in the rectum, what is he going to be encountering? The valves of Houston. How many to the left and how many to the right? 2 to the left and 1 to the right. Okay? And as you see, we can go up. This is a sigmoid colon, maybe about 40 centimeters or so. No, just to tell you that a lot of patients now go for, this is no more used, right? But a lot of patients now go for colonoscopy, okay? And very, very sad. But you have once again to go to the right person. Because sadly a lot of people go for colonoscopies young and their colon is being perforated. And when what happens when the colon is perforated, what happens to the patient when the colon is perforated? By the gastroenterologist. What's the outcome? Not good at all. So right here in this place called Kingston, a lot of madness is being done. Yes, very sad to say to you, but a lot of madness is being done. And that's why you can't be. Then what happens to the poor patient is that they shop around. And they, rather than boy go to the good one, they go to the what? The cheapest one they can find. And the cheapest one sometimes is the one that is really getting into problems. My wife, many times, got to patient and the colon is perforated. Right. So, not a good story, okay, so. And when that happens, then fecal material is now getting out into the abdomen. So that can be fatal for the night. Yeah. So colonoscopies, you're really so like I'm telling you. So as we're telling to the dean, I thought the dean was talking to me. And I had to say, okay, they are surgeons, then they are surgeons. They are surgeons and they are surgeons. Right? And as I said to you, my students are walking and walking over to it, right up at a certain hospital room, no more to point in any direction. Right? He says, you know, Mr. Gardner, I got an anastomosis. And I passed the patient's bed, you know. And what did I tell you last time? The patient smells like a sewer. You hear that, Sam? The patient smells like a sewer. Right, so I don't know why some of these surgeons are not learning the proper technique. Right? And Dr. Lodenquai knows very well. So I've never heard of all of his colleagues like Dr. Bora Singh and all of those kind of people. Never heard them encounter these kind of problems that some of them are doing. The leaking, impatient young lady on the bed smells like a sewer because inside it's leaking. Even simple operations like appendectomies, I can't tell you where the poor patient ends up. So they must have skill. The surgeon has to have skill. Hands like an artist, right? The artist who can Picasso and all that when he draws. So the surgeon has skill in his hand, right? So you have to have skillful hands and talent.
Mr. Gardner.
Okay. No, give it hands. Yes.
Anthony is asking if the instruments coming on spot.
If the bomb
If the instruments are coming in the spotters, Dr. Lodenquai every year sets the bomb gun. Every year the bomb gun is there. I've never seen it out there, and this is now going to be put in, it's called a stapler.
stapler and the bomb gun.
Okay, so let us start. Okay?
Yeah.
Let us start and just have some fun. Okay. So we have to zoom in hard on him, look. Hard. Let this area fill up the screen. Okay, come back up. Alright, so we are going to have a little fun. L5. L5?
Yeah.
S1. This boy is called what?
The same.
Sacral promontory. L5, S1, sacral promontory. S1, S2, S3, S4, S5. This little boy here is called coccyx. Zoom in now harder down in that area. Come down even further. No, you can't go down anymore, eh? No? Okay, so there we are now, the tip of the coccyx. And then I see a magical structure here. Right? Magical. And that magical structure that I'm looking at is anococcygeal raphe. This structure right here is called anococcygeal raphe. So this is the tip of the coccyx, and then just a little anterior and inferior to the tip of the coccyx. This happens. So pass a finger, Crystal. Crystal, pass a finger. Come. No, don't pass a finger. Tell the other. Here. Crystal, that's a lot of rings, you know, trying to find something that is moving. No, just touch onto my finger like look at me. See what's happening? So this finger here now is the puborectalis. And the puborectalis is just surrounding the anorectal section. So it's like up like that. So the rectum is descending and then I'm coming right around like that. So it's forming a sling. And look what that sling is going to result in now. Right? A curve. See that? And that's the anorectal flexion. Okay, and that curve is formed. This is, I'm pulling, this is called the what? The puborectalis. Okay? The puborectalis is a part of the levator ani. So when the rectum passes through the pelvic diaphragm, it's now going to change its name and become anal canal. Right? And it's slung by the puborectalis muscle. And that sling is very important. And if the nerve supply to that sling is interfered with, you can get all sorts of incontinence. Because very much involved with above there is a large storage area called the rectal ampulla. So when the people are doing surgery, they're very, very careful of what they're doing down there. Because you want a patient to have continence and all of that after that. You don't want anything to go wrong. So if that's the tip of the coccyx right here, come back right here. Okay? So you can see that look how we're going. We're going at this angle, right? And then now look what angle we're going. First we're going at that angle, and look what angle we're going at. You see that? We're nearly taking a 90 degrees. So this red probe is when you start to pass an instrument up into the anal canal. Right. Yeah, what I mean in terms of the direction of the move. Or the finger, you're doing a DRE. Okay, so you're going to do a DRE, alright? And you're going to inserting the finger there to do a DRE. And then now, when you push that finger in, you can see now, as I say earlier, more so an instrument is passed, a rigid instrument is passed like this. You have to know how to navigate. But what I'm showing you most important is what we did a while ago. And that's the sling. So it's a sling, it's the puborectalis that we're seeing right here. That is coming right around to form that sling. So this is anal canal, 3.8 centimeters. And then now we're now entering into the land of the rectum. Okay, so all of this coming up here is rectum. So this, as we see, is sigmoid colon. So once we pass over the pelvic brim, right, on the left side, when we're coming over the pelvic brim on the left side, that's the pelvic brim here, and we're going down here into the pelvis. We're going down into the pelvis here. So when we're passing over the pelvic brim, then descending colon is going to be coming sigmoid colon. And that sigmoid colon now will have a mesentery, a V-shaped mesentery. Okay, so the descending colon doesn't have a mesentery, has just peritoneum on its anterior aspect. As it passes over in relation to a lot of important structures. Right? Passes over in relation to a lot of important structures. And in the surgery exam, they will ask a lot about what is happening there. Okay? You must know what is happening right here. So all the examiners like to ask. And they're talking to two surgeons there beside me here. So, Dr. Lady with the letter D, right? What's the ask about ureters and all of that kind of story. Remember? So, then we go over and we're into sigmoid colon. Then sigmoid colon, as you see, comes along here. And then this is, yeah, right back here. This is S1. Yeah, you have to come down and down. Yeah, right on there. Perfect. Back up and there, 300. So this is S1, S2, S3, S4. Then we're seeing the what? S1, S2, S3, S4, S5. Then we're seeing here the coccyx, the tailbone. Okay? That's the tailbone right here. And that's the anococcygeal rapid. You know, a lot of people sometimes get some bad kind of falls and hits and all of that. And then fracture and displace the coccyx. And that will become excruciating pain for the patient. Patient is you're sitting down comfortably, the guy is sitting comfortably. You have to come sit on some kind of special cushion and all that kind of stuff. So then it damage to the coccyx. Okay? And then now we'll see that's the anococcygeal rapid. So the rectum is going to start. This is a S1, S2, S3. This is where the rectum begins. So the rectum begins here. And then the rectum is going to end right at that level right here. Just a little below the tip of the coccyx. And you can see where now the direction is changing. So that's the rectum. And the rectum is going to be divided into an upper third, a middle third, and a lower third. The upper third has peritoneum on its anterior aspect and lateral aspect. The middle part has peritoneum just on its anterior aspect. And then in the lower third, it is devoid of peritoneum. Right? In the lower third, it is. In the lower third, it's devoid of peritoneum. Now, I have a real female specimen over here, but I'll just show you on this. Okay, so we see on this model right here. Here we see on this model right here. Quite a nice model. Come off a little more. Okay, there. Come, go back down. Go. So there you can see the rectum right here, and the peritoneum is going to come off. There's a little adhesion here. Don't worry about that adhesion. when the peritoneum comes down and reflects off the vagina. So in the female, it's called a rectouterine pouch, but in fact it reflects off at the level of the vagina. In the young girl, it goes further down, right? Further down. And then now in the adult, we see it going right to the level of right here. And what I'm pointing to is the external os of the cervix. See the external os of the cervix? So this model conforms 300%, right to exactly where it should be. So it therefore goes and reflects off onto the upper quarter of the vagina. And this is one of the most important spaces, and this is referred to as a pouch of Douglas. Right? And radiologically, there is usually a little fluid in the pouch of Douglas. So if we see a little fluid in the pouch of Douglas, we're not to be, oh, no. There's always, my daughter always says, you always see a little fluid in the pouch of Douglas. Right? However, this is the most dependent of the spaces. Or anything that is up, say, in Morrison's pouch, right? Hepatorenal pouch, any fusions, anything that's happening up there is going to leak down the paracolic gutter, the right paracolic gutter, and then enter into the pouch of Douglas. So we see that the peritoneum comes, and we see now that the peritoneum is, watch what's happening, the peritoneum is coming here, and the rectum, by the way, we see is continuing down. And the rectum is in relation to what? Where does the rectum end in relation to, Brittany? In the female, no, we have female here. Right, the posterior wall of the vagina. Okay, so the rectum is going down, right down onto the posterior wall of the vagina. And there's very little separating the posterior wall of the vagina from the anterior wall of the rectum. And just to show you a specimen right here. Let me show you a specimen here. We're going to come back to it. Just to show you a specimen, this is the actual specimen right here. Okay, so the actual specimen of the female now. Okay. So in the female, here we see the female, and you see that to perforate the colon is a very easy thing. Look at this, look how thin the wall is. Right? The wall is very, very, very thin, you know. See how thin that wall is? So an instrument can easily perforate it. And also, that is why very easily you get diverticular disease. So when there's constipation and this and that, and the patient is straining and doing all that other stuff, diverticular develop very easily, mucosal outpouchings. Okay? So look how thin the rectal wall is. This is just looking at this here and this here. How much millimeters you think this is? Come and look here and tell me how much you think that is. Brittany, how many millimeters you think that is? Look at that, Patrick. How much millimeters you put up here? I say this about 2 millimeters. 1 to 2 millimeters. Right, 1 to 2 millimeters I see right here. See that? Look at that. You know how thin that is? That's very thin. You can see how it's very easy to what? To perforate. So in a colonoscopy, very easy. Okay? So colonoscopies, we all have to go for colonoscopies. So you better be in the right hand. Okay? And then you can see here, all of this area is called the rectal ampulla. See the rectal ampulla? And there you can see this is the posterior wall of the vagina. That's the posterior wall of the vagina. And you can see, look what it is. There's nothing separating the posterior, the anterior wall of the rectum from the posterior wall of the vagina. Okay? In the male, there is something that is very thick and well developed. That's the fascia of Denon-Villiers. But in the female, there is nothing really there. And my professor was telling me in the Far East, they have some kind of disease there, like we would have some kind of special thing that they have some sort of, I can't remember, but my prof would tell me, like in Indonesia and all of that, there's a separate ward just to deal with patients like that. So in the Far East now, there's some special kind of conditions that affect it, and a lot of women end up with what's called rectovaginal fistula. It's a bad story, because fecal matter is just coming into the what? Into the vagina. Right? So it's a very bad story, okay? Alright, so luckily in this part of the world we don't have that. Alright, but there still can be pathologies and all kind of things, and you'll feel that it's very easy for the patient to end up with a rectocele. Alright? So the rectum can kind of permeate into the what? Into the posterior wall of the vagina. And when you are examining your patient though, you will see that when you examine the vagina, you may see the posterior wall of the vagina like a big bulge coming in. And that's called a rectocele. Or the anterior wall of the vagina, another bulge coming in. That's a cystocele. And we can see from above coming down an enterocele. Right? And the cervix itself can be coming up. So you can see the cervix right at the introitus, or come right up. Okay? So there we can see that that's the rectum, but very important to appreciate now the pouch of Douglas. So the pouch of Douglas now is going to go, and see I brought the specimen now. So this is the posterior fornix of the vagina, and the rectum is right on the posterior fornix of the vagina. The anterior rectal wall is right that down in capitals, right on the posterior wall there, right? So the pouch of Douglas is just, so we just say that the pouch of Douglas goes right, we should say, let's correct that statement, the pouch of Douglas is right on the posterior fornix of the vagina, okay? And it's going to go right to the level of the external os. See here, so it goes right to the level of the external os, goes right to the level of the external os, and then reflects off. And then the peritoneum is going to cover the uterus, right? Because they're covering the uterus, and then coming down and then reflecting to form another peritoneal space. That's called a uterovesical pouch. And that uterovesical pouch is at the level of the internal os of the cervix. So the pouch of Douglas goes down to the level of the external os of the cervix, and the uterovesical pouch goes to the level of the internal os of the cervix. So of course this is used for many kind of procedures. So if there's blood, say for example there's a ruptured, like an ovarian cyst, okay, an ovarian cyst, a ruptured ovarian cyst, and ruptures, then now they will do what they call a cholescentesis. You can tell me the name, right? You're the lady, you have a lot of ONG blood in her mother's a big ONG lady. Right? Very good. So they call it cholescentesis. Yes. So they will put an instrument through the posterior wall of the vagina and try to remove that blood that is in there. Okay? So when ovarian or the person may have a very bad endometriosis, but it's usually not for endometriosis, but usually when an ovarian cyst ruptured. So I had a very nice student, she was sitting right in front there a couple of years ago, and we became very good friends, very, very nice from Trinidad. And sadly, on the wall, right in the hall, she was in terrible pain, and she called, the guy like that. We had to rush her to A&E, and what they found out is that an ovarian cyst had ruptured. It was a bad story. Maybe for a year she was out of medicine. Right? So it was a very bad story. So it can happen to a lot of young ladies now who are getting what? Ovarian cyst, polycystic ovarian disease, PCOS. Now very important is the peritoneum. So you must have a firm understanding of the pouch of what? Douglas. The pouch of Douglas is going to go on to the posterior wall of the vagina. Right? The posterior wall of the vagina, and covers right at the level of the what? The external of the, yes, posterior fornix. However, the rectum is going to continue down, 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 and it's going to relate it to the posterior wall of the vagina. Okay? And this boy here is white in white, is the anococcygeal raphe. Okay, and that's where roughly at that down there it's going to undergo its curve to become the anal canal. Right? So that's what happens in the female. Now just to say in the female, this is what happens in this part of the world. The uterus is antiverted and antiflexed. In Asia, in China, and all of those areas in Indonesia, 80% of the women have the uterus flipping back this way. They have a retroverted uterus. Okay? Right in this part of the world, they have an antiverted, antiflexed uterus. Okay? Alright. Let's look and go right. Okay, in the male, so what is the situation now in the male? So in the female, we're going to see it right here. In the female, we're looking at the posterior wall of the vagina. See it right there? Zoom in hard in it. I want you to appreciate this really very much. Right? So there you can see there's very little. So any pathology that's going to develop, any rectal cancer and all of that sort of stuff, and some serious problems. Okay? So, and you can see what is happening. That's the posterior wall of the vagina right here. Now, sadly, just to tell you, we're going to do a lot of it in OG. That's the posterior wall of the vagina, and see the anterior wall of the vagina. So we can see that the vagina has a far more muscular wall. The vagina is more robust, okay? That is the rectum here, right? You can see the thickness, so there's a lot of muscle around the vaginal wall, okay? But that's smooth muscle, okay? All right, and then we can see now that this rectal wall is very, very, very attenuated. Okay, in the male now, what happens in the male, there is a rectovesical pouch. Okay? So this is a distended urinary bladder. So this person when they died had a distended urinary bladder. So this is a midline section. So we're seeing here, come off of it a bit. Yeah, so we see here now that's the pubic symphysis. This is the penis right here. Okay? Suspensory ligament of the penis. And then we're seeing the rectus abdominis. Right? And then Sam. Sam, you're looking or you're not looking, Sam?
Okay.
Sam, what am I holding on to here? What is that I'm holding on to? Let me show you, doctor. What is this that we're holding on to here? Very good. 300 marks. The pyramidalis. Okay? That's the pyramidalis muscle. And that's the rectus abdominis right here. This is a distended urinary bladder. Okay? And we can see now that the peritoneum is going to come and reflect off inhalation. But come right here. Zoom in hard on that. The peritoneum is going to reflect off right at the level of the tip of the seminal vesicle. Right? So the peritoneal reflection will be right at the level of right here, at the tip. So take a picture of that and label it. Right? Reflection is occurring at the level of the, take a picture of that. Reflection is occurring right at the level of the tip of the seminal vesicle. Right? And then it's going to reflect onto the superior surface of the urinary bladder. So the superior surface of the urinary bladder will have peritoneum. All other surfaces are devoid. Okay? Then we're going to see, that's the urinary bladder. So there is a prostate right here. See, all of this is prostate right here. All prostate right here. That's prostate. So the neck of the bladder, the prostate has the shape of an inverted pyramid. So that's the prostate, and then coming right up here are the seminal vesicles. So in the male, there is something that is well developed here. See, it's very well developed. And that's called the fascia denonvillus. This is fascia denonvillus. And that fascia denonvillus has a retroprostatic fascia and a prerectal fascia. So on the front of the rectum, there is what's called prerectal fascia. And then separating this from urogenital structures, is retroprostatic fascia. And retroprostatic fascia and prerectal fascia form the fascia of Denon-Villiers. And this rectal wall is freely mobile because in here, this is loose connective tissue in the space, and that space is called the space of Denon-Villiers. Right? It's just loose connective tissue. So when they do a DRE, the mucosa is just freely mobile over the wall, freely moves over the wall, the prostate. So when they do a DRE, as you can see, they have to come quite a bit up. You can see that. So the rectum has now, as I said, prerectal fascia. The peritoneum is going to come down, we said, upper third peritoneum on the anterior and lateral aspect, lower third peritoneum right here is just on its anterior aspect, middle third, my apologies, and then lower third, everybody is devoid. See, all of this area here is devoid. Okay? So they divide it up into thirds, you know. When we look at it, this kind of lower third is a bit longer than the rest, eh? Yeah, but that lower third is quite a bit longer, but we leave it all alone. Right? But the textbook is lower third. But to me, it looks more like the lower half, but leave it all alone. So there you see the reflection here is coming off at that level. Okay? And then where it makes a swing around, this boy now is the puborectalis muscle. So the puborectalis, right, they get married into what? The levator ani. Reason that good? You hear that, Crystal? So one day for you, Lord, listen what's going on. Some magic will happen. Is that so? Very much so. Right? It's going to change your day. Right? So what is happening at the puborectalis now? And then to form this structure here. And we can see it's in three parts. 1, 2, 3. And this tripartite structure is referred to as the sphincter ani externus. This is a tripartite structure. Sphincter ani externus. So what is happening right here, Anthony? Look at it right, Anthony. Is that the sling is formed here, and it's going to get a blending of the muscle. And that structure has a deep part, superficial part, and what you saw histologically in this slide yesterday, the subcutaneous part. So deep, superficial, subcutaneous. And there's some strands that come in right here. And what are the name of those fibrous strands written in that come here that make this area puckered? What are the fibrous strands that come down into the skin? The fibrous bands, and they chew like that. What are they called? That's they're called corrugator cutis ani. The corrugator cutis ani. So right here we're looking now at the anal verge. That's the anal verge. You have to zoom down hard now, love. Hard as you can. You have to come down more. Maximum. You can't come down anymore. Yeah. You focus. Yeah, that's beautiful. Right. Excellent, my dear. So there we can see now these are the columns of Morgagni. See the columns of Morgagni? And those columns of Morgagni will have, they will be about 6 to 10? 6 to 10 or 6 to 8? 6 to 10? Okay, here it's about 6 to 10. And those columns come down. And then in between the columns, they're connected by these structures that are called the anal valves of Ball. So we're bucked up Mr. Gay.
Wait.
Yesterday, the glands of Gay, the glands of Ball. So Ball did a lot of work around this area. Gay worked at the verge. Right, what he was doing there, we don't know. And then now, Ball was decided to go further in. Okay? Leave it all alone. And then now, we have now what are these little semilunar little valves, and they connect the anal columns. And they are called the the anal valves are born. And then right where the forceps is, I'm taking the forceps and pushing it down into, and I'm going into what is called a crypt or a sinus. This is a crypt or a sinus. So the depth, the lowermost part of that area between the columns, that's referred to as the crypts, the anal crypts or the anal sinuses. And into there will open the glands of Ball. Okay, so there's some serious boys, don't joke with them. There's some very serious guys that open here. Okay, so all around here, and then this, these little scalloped, just these little scallops of the anal valves form what's called a pectinate line. Right? So when we look at it, and pectin means what? Comb. So just like the little fingers of the comb. Reasonable, see the little fingers of the comb? There, that's the little fingertips of the fingers. So there they are, the little tips of the fingers there. Okay, so each little one forms a what? And that's called a pectinate line. And that pectinate line is where histologically stratified squamous epithelium is going to become columnar epithelium. So this area is proctodeum. Okay, here this is developed from the cloaca. Down here we have this is proctodeum right here, right Patrick? Yes, B? You there with me, Patrick? Yes, yes. Alright, so there we can see the columns, right? So there we see the columns right here. So these are called the columns of Morgagni. And Dr. Lodenquai was saying usually there are how many primary sites? No, primary sites for hemorrhoid.
Oh, 15? No.
3.
Primaries.
And in the lithostomic position, they are at what positions?
3, 7,
6, 12. Really?
No, 3, 7, 11.
3, 7, 11.
The minor one.
3, 7, 11, Patrick. 3, 7, 11. 3, 7, 11. Right? So we're going to find right here. This is a what? Portosystemic anastomosis. Right. So there's an internal plexus of veins, a hemorrhoidal plexus of veins. And this is where Pyle's internal hemorrhoids will develop. And out here is where external hemorrhoids will develop. Reasonable? And then Dr. Lodenquai was saying there were 3 sites, primary, and how many secondary?
5.
Brittany, how many secondary in the oral? Yes, 5. And 5 and 3 are 8. And the ones that are injected are which ones? The primary ones or the secondary ones? Yes, which ones you want to inject? Sclerosing agents into the primary, the secondary, or the primary. The primary. So injections are given at 3, 7, and 11. And it must be above the pectinate line. Because if you put the needle below the pectinate line, the patient will be excruciating pain. Right? So you have to be very careful. So there you can see clearly the internal anatomy of the anal canal. 300 marks. You see the columns, right? You see the anal valves, and we see the crypts. And those crypts, big textbooks are written just on what happens in those crypts, right? Because those crypts now we say have glands, and if those glands become infected, and the infection becomes progressively worse, breaks down, ends into the Ishiorectal fossa, and we get fistula in anal, right? And they follow good stalls along, how they're going to travel. Okay? Right, so there you can see, so you're pushing the probe right into the crypt or the sinus. See the depth of the sinus, look how far I've gone. Okay, and down in the depths there will open the glands. Right? So that's we're seeing in the male. So in the male here we said there is there. Now let's look at another specimen. Okay? So just put this specimen on top of this one. The young lady is here thinking she doesn't want to get the like all these specimens beside her, so we'll do another one. So this is a special condition when we do UG called bell clap testis, right? When you marry, we call it bell clap testis. This is a section of the male organ. Put that here.
Male organ.
This is crazy. Isn't that what it does? So there we can see now the rectum. Yes, so you see the rectum right here? Sure. See it right here? So this is a male cervix, as you see. Okay. Kidneys are up here. And there we can see now the sphincter ani cervix. See it right there? Sphincter ani cervix. That's the anus right here. Okay? And we're opening up. We're opening up. And we're getting into the rectum. And we will see a valve, Houston. See it right here? Okay? This, remember we said 2 to the left and 1 to the right. This is a 1 to the right. See right there? So this is a permanent thing. So now you have to zoom down a little. There, right. Look at the difference. So this is a permanent shelf. This is the valve of Houston. Okay, this is the 1 to the right. Okay? And then we're coming up, we see some guys to the left. See there, Brittany? See 1 to the left there, sweetheart? See 1 to the, see this is 1 to the left. The first one, or the last one that is encountered when the instrument is going up. This is the last one that's encountered. Okay? This is the first one that's encountered. To the left. Then this is the middle boy. See a middle boy right here? So 2 to the left and 1 to the right. So that's the prostate. Okay, and you can see that when they have to do a DRE, so Crystal is going to have to do it sometime on the ward when you're at the hospital. In the morning you might have to do like about a lot of them, isn't that so? Like about how many, Brittany? About 7. With the patients are lined up, 7 of them. Reasonable, and you can see that you want to get to the prostate. So if you want to get to the prostate, you can't just now just put the finger in like, oh yes, I did it. And it's all. No. But if you do DRE, you have to go right up. Look how far I've gone up. See how far I've gone up with my index finger to reach to the what? To the prostate. See how far I'm up? Way up. Okay? Right, so you have to go back up. And then we're feeling there. So right here, look what we're looking at. That's rectum. These now will be all the anterior relations of the rectum. See what the rectum is going to be related to? So the rectum in the male has its upper 2/3 with peritoneum, forming the rectal vesical pouch. Okay? And then now the lower third is related to what? Lower third is related anteriorly to what? Base of the urinary bladder. What is it related to? Base of the urinary bladder. And the base of the urinary bladder, Dr. Lodenquai made a nice little thing to remember it. The base of the urinary bladder, it's not related directly to the base of the urinary bladder, but there are structures that intervene. And see the structures that are intervening? Right? See the structures that are intervening? So the structures that are intervening now are they big boys? What are these boys? So when you do a DRE, if they're in a healthy state, can you normally palpate them, feel them, Brittany, yes or no? No, you shouldn't be able to feel them, only if they're become diseased or pathological. Right? So that's the seminal vesicle. So Dr. Lodenquai made very interesting. SUV. Remember that? What did I say a while ago? So on the posterior surface of the urinary bladder, the base of the urinary bladder, separating the base of the urinary bladder from the rectum on either side, SUV from lateral to medial. S, seminal vesicle. U, ureter. See the ureter coming in? See the ureter's there? See the ureter's coming in? and then V, vas. See, and look how big the vas is, Anthony. You see how big vas is here? This vas here is powerful. Look, S, that looks like a bunch of grapes. Looks like a bunch of grapes. Right? S. No, by the way, it's like a cake. This is under a lot of pressure. Because in the cadaveric state, if you go to cut into the seminal system, everything under there is under what? Pressure. Alright? Everything is under pressure. So even when the person dead, you know, when you go into the scalp, straight up, seminal fluid. Reasonable? So that's the seminal vesicle. Then, because I know, because I've cut in a number of times. And you have to be careful when you go to cut. Right. Then, the ureter, and then V, this is the vas. So look at the vas, give a chance. So this vas here is coming from, reverse. It's coming from the testis. There's the testis. And you have to know this for this exam, because this is anterior abdominal wall, so this is peritoneum that covers this, and it's called the tunica vaginalis. The tunica vaginalis, right? That's the visceral layer of the tunica vaginalis, simple squamous epithelium. And there you can see the vas, that's evident, but this big boy coming off, muscular structure tube, is the vas. See the vas right here? That's the big vas right here. See the vas? And the vas here, and the vas now, on the posterior aspect and the dorsal will form the ampulla of the vas. So the ampulla of the vas will meet that seminal vesicles of the form the ejaculatory duct. Okay? And then now, below this, Brittany, we're going to the exam now, and the examiner picks up this and asks you, what is this? You tell me what is that? Yeah, what is this that I'm lifting? Let's have fun. What is this? Don't feel stressed over it. What is it? Right, Sang is telling us. Retroprostatic fascia. Right? Retroprostatic fascia. That's retroprostatic fascia, right? And then on the rectum here, see the rectum here? What is this called? Prerectal fascia. So that's prerectal fascia, okay? So you can see that the rectum, and you can see it's a devoid. It's the peritoneum right here, the crystal, and the peritoneum stops. So all of that part of the rectum below there is applied there. Okay? So the rectum in the male, the lower third is related to the base of the urinary bladder with SUV and rectovesical fascia, which is an upward continuation of denonvillous fascia. And then below, you'll see. Now, when we see right here, Crystal, watch Crystal. When you do this DRE on this patient, just quickly, you're going to do a lot of DREs, you're going to feel it like that, and you're going to notice that it's mobile, freely mobile, and it's like that. There's a oomph, right? If it's hypertrophied, it will feel spongy like that, and a bulge. So you feel a bulge rather than a oomph. And then now if it feels, if it's not mobile, it's hard, worse still it's all feeling stony, then it's a bad story. Okay? So it should be freely mobile and more. Okay. Now let's get back to it. Okay, so we can go back and use this image. Alright. Now, we have looked at the anterior relation. Well, what happens to the rectum behind? Okay? So, my good friend, his father, oh, it was a terrible story. God. Rectal cancer. Rectal cancer. I went to see him, I think one of those big surgeons, the surgeon had to do what Dr. Lennon was doing, abdominal, pelvic, and just pull out everything. But I saw the x-ray of the man's vertebral column. It was a disaster. It's like you couldn't see any sacrum there again. Horrible. Right? Poor man. But he survived the operation and went home and lived for a number of years after. I was able to take him. I took him home that night with a top professor, you know. I took him home that night. His son got married. And the reception was at the Morgan Harbour. And I drove him that night. It was the same man that I saw brought back from surgery. And below his bed was a bottle that was full of blood. He never ever thought he'd survive. He survived. Okay. Anyway, so that posteriorly, so we get the sacrococcygeal curvature. So posteriorly, the rectum is following now the sacrococcygeal curvature. Sits in the concavity of the sacrum. Sits in the concavity of the sacrum. And is held in place by what, Brittany? See these lights? Look at these lights. So when the rectum becomes filled, right? The rectum, the sacrum is curving like that. So the rectum would like to fall down. It's like would like to fall down, but something pulls the rectum up. So what supports the rectum? Waldenquai fascia. 300 miles. So along here, you see that white structure that we're seeing all along here? That's Waldenquai fascia. Okay, so if you look down in here, so the rectum is going to be from, this is S1, S2, S3. So you'll see very important when we get down there, the sacral nerves. So the lower three sacral nerves, so S3, S4, S5, okay? S3, S4, S5. So sometimes in rectal cancer, the patient comes with pain down the back of the thigh, okay? Because we have infiltrated the parts of the what? The sciatic nerve, right? So the posteriorly is going to have Waldenquai fascia, and then now it's going to be related to bone, muscle, nerves, blood vessels, lymphatics. Bone, muscle, nerves, lymphatics, blood vessels. What are the winners? Lower three sacral segments and the coccyx. Bone. Muscle. What muscles will be there? What muscles will be there? Piriformis and coccygeus. Piriformis arising from around the sacral foraminal S3, S4, S5. Right? And then also the coccygeus muscle. So that's bone, that's muscle. As I said, when I looked at my friend's father, the professor, you couldn't even see a sacrum. Terrible. Okay? And he had a lot of pain. Okay? A lot of pain. Bone, muscle, nerves. So those are the sacral nerves and the coccygeal nerves. Then also it will affect bladder function and rectal function. So pelvic splanchnic nerves. Okay? The pelvic splanchnic nerves is going to affect the sympathetic trunk. So the sympathetic trunk is traveling right down there. And then also there's a ganglion called the ganglion impar. So the sympathetic trunk, the pelvic splanchnic nerves, the big boys that are emerging, S3, S4, S5, and the coccygeal nerves, all of these things will be affected. And then blood vessels. Which blood vessels? So there's a median sacral artery, and then now those branches of the superior rectal artery. Isn't that so? And then the middle rectal, okay? Not the middle rectal, but this is superior rectal, median sacral. Corresponding veins and lymphatics. Patrick, what do we get about lymphatics? There's a special story about lymphatics around here. Around here. What about
Watershed area.
No, there's some sacral lymph nodes. The rectum up here.
Yeah.
Right, sacral lymph. The mesorectum, yes. Okay? So we can see what is happening, okay? What about in the female? In the female, what about the posterior relations in the female? They're the same as the male. Okay? The same as the male. superior rectal artery. So we don't have a problem. We know about the relations of the rectum. Yes or no, Crystal? Crystal, what are the anterior relations of the rectum in the female?
They have.
Proof of the pudding is in the eating. Very good. What are the relations now of the rectum in the female? Anterior relations.
The posterior wall of the vagina.
No man, that's way down. What do we start with? Pouch of right. What do we see? What's the anterior relation of the rectum in the upper 2/3? Upper what? 2/3. Pouch of Douglas. Okay, what's going to be contained in the pouch of Douglas? Wow, very good. Which may be up to 40 centimeters long. What else? Maybe some ileum. Yes. And what, look here, watch here. What may be just resting on the rectum in the female? Look at that. And irritating. Oh no, sorry, Brittany. Irritating. What may be resting on the rectum in the female? Uterus. Right? The fundus of the uterus. In a uterus that is flopped right back. A retroverted uterus. Remember, 80% of Asian women of that part of the world, they all have retroverted uteri. In this part of the world, it will be associated with infertility. In the other part of the world, no problem. That's a practice. There is no problem. Not at all. Just relax. So the upper 2/3 is pouch of Douglas. The lower third is posterior wall of vagina. And the level of reflection is where? Onto the posterior fornix of the vagina, the upper quarter of the vagina, isn't that so? Has peritoneum of the rectouterine pouch of Douglas. Yes? Okay. In the male, what are the anterior relations? Right. The what? Post. You see, I didn't mention post today because my colleague has another opinion on pouch of post. Mentioned, you know, I'm going to get it in hot water. Right? Right. So in the male now, rectal, the cycle pouch, right? There's some people in a bit of controversy, or a lot of controversy about post. So we won't go there right now. So in the male now we get that, and then we'll say below that base of the bladder, urinary bladder, and prostate. Denonvillous fascia. Denonvillous fascia formed by retroprostatic fascia and prerectal fascia. The older urology surgeons of way long ago, that retroprostatic fascia was called the pearly gates of the prostate.
Pearly gates.
Okay? So those early surgeons, you know, those early surgeons, they would have all the early surgeons different than the surgeons of today. Like my good colleague was telling me a lot of stories because he used to assist Sir Harry Anaman. And he says he could operate any surgery, from head, skull, brain, right down to the foot. All the surgeons, right? They would do everything, boom. The modern surgeon is a special area. Okay, so we're all right with that? Blood supply to the rectum, anal canal. Blood supply to the rectum and anal canal. Let us ask, is her name Melissa? Melissa.
I'm gonna start today, yeah.
No man, you. No, leave the baby alone. Blood supply to the rectum and anal canal. Relax. Okay. She said superior rectal. Coming from?
Woo.
Yeah.
Passing it today again.
No, I showed you on the specimen.
Inferior mesenteric.
Right. Inferior mesenteric divides into two branches.
Right.
Left colic
Yeah.
and
Right.
rectosigmoid.
Okay, rectosigmoid.
Yeah, and remember sigmoidal branches.
So it will like
And then we have the superior rectal And the territory in between the last sigmoid and the first superior rectal is called critical point of Sudetic. Okay? Relax. Superior rectal dividing in the lithotomy position into 3, 7, and 11. Okay? And remember that in the submucosa, there is an arteriovenous shunt of Haller. So there's an internal venous hemorrhoidal plexus and an external. The internal ones will give rise to piles. Okay? So sometimes even when the female is pregnant, in the latter stages of pregnancy, they may get hemorrhoids, right? Because of compression. Okay? But those hemorrhoids will resolve themselves. Right? But if people have diet and you're straining and all kind of crazy stories, then they will develop hemorrhoids. Right? And when they get hemorrhoids, what color blood they bleed? Bright red. Not venous, though it's a venous system, bright red blood. Because of the shunting of the shunt of Haller. Veins direct, some arterial going into veins. Relax. Below the pectinate line, there's a, by the way, also a middle rectal artery. What is that man's name?
This one?
Yes.
For Anthony?
Anthony. Yeah, Dr. Lidding. I thought of Anthony this morning. The name. Dr. Lidding, who knows more names than me. Always calling on Anthony. So Anthony.
No, Anthony.
This is where, no, this is Anthony, but what's your name?
Got it.
What is his name, Anthony?
Got it.
Both three? You know him as that Brittany?
That's what he told me, sir.
You guys are friends? We can leave that alone. My Brittany always calls. Yes, so go for it. Just relax now. Middle rectal artery, what about it?
It supplies.
Where is he coming from? We have him from.
From the inferior mesenteric.
Lord, you hear that, Patrick? Middle rectal artery coming from inferior mesenteric. So you mad as hell.
Because I think it would have ended
Middle rectal artery is coming from where? Yeah? Middle rectal is coming from?
internal, yeah.
Yeah. Anterior posterior division. Anterior. Right?
Oh yeah, that would make sense.
Relax. What can you tell me about the middle rectal artery? Supplies mainly the muscular wall. Right? Usually in the female, no middle rectal artery. Replaced by what artery? Uterine artery. In the male, middle rectal artery, oh, business too much with the rectum, but business a lot with the prostate. Gives prostatic branches, right? Prostate causes the middle rectal artery to come. Okay? Then now, the inferior rectal artery is coming from where? Inferior rectal artery is coming from where?
Put them down.
Not at all. The internal pudendal artery. Okay? That internal pudendal artery. Relax. Just relax. Below the pectinate line, what's the nerve supply? Below the pectinate line, somatic. Above the pectinate line, autonomic. Parasympathetic and sympathetic. Parasympathetic will be coming from where? Pelvic splanchnic. Sympathetic from the hypogastric plexus, right, Patrick? Which hypogastric plexus do we want? The inferior hypogastric plexus. Below the pectinate line, somatic. You can feel it. Really, this is dull pulling up the pulse. So you put the needle there, not too bad. But below, horrible. Right? What's the nerve? Inferior rectal or inferior hemorrhoidal nerve. Okay? And that's from the internal pudendal. Dermatome, right here. Always in the example. You hear him, Patrick? S2.
S3.
S3. You know where S2 lives? S2 lives at the back of your lower limb. Between the anterior and posterior axial lines. That here puts your
Close enough,
axilla
yeah. S4.
that area, red called the S2 area. You stand on S1, you walk with S2, you sit on S3, and you wipe S4. No.
S4.
You stand on S1, walk with S2, sit on S3, and you wipe S4. And this in the canal is S5. Relax. And then very interesting one, you'll have what is called the anal wink.
Oh,
The what?
anal wing.
Yes. Alright. Okay, so all of that. And remember that the sphincter anal external has three parts. A deep part, so the sphincter external anal sphincter is supplied by that inferior rectal or inferior hemorrhoidal nerve. Now relax. Just what? We come to the most important topic for today. So by the way, the morning when I was to do there with the coordinator on this daily rescheduling a lecture, but that morning I was to do rectal and feeling very sick, not good at all. Like a dead man. What kind of man? Dead man. Reasonable? But I said, no, boy, I can't lecture feeling like a dead man. You really end up dead. So what is the most important topic for today?
Ishiorectal fossa.
The ishiorectal fossa. A lot of your patients are going to home and they can't even walk in the clinic, you know. They can't even walk in. I went to see one of my surgery colleagues and I saw a poor man patient outside. And the poor man just hardly walk after it. Hardly walk. He was in a terrible state. So I then asked my colleague when I went into his office to see him, just as a friend. And I said, by the way, the patient that just keep putting what happened to that poor man? Ishiorectal abscess. Right? So this area here, when you look at it here, this area is the ishiorectal fossa that we're looking at. Okay? And that ishiorectal fossa is going to, there are cushions, fatty cushions around the anal canal that keep the anal canal closed. Keep it what? Closed. And when stool is passing or gas is passing, then we have to expand and open. So there are cushions around, and they're fatty cushions. And that fat is a special type of fat. Crystal said she had to go early, she told you. That special type of fat is known as what kind of fat? Okay. The fat around here is a special kind of fat. What kind of fat they call it? Loculated. There is loculi. Okay? So there is loculi around the anal canal. Okay? So the ishiorectal fossa, boom. See there? So Brittany hold them up like that. Perfect. And there, it's just there like that. Turn tilt him a little like that. Hold him, you have to hold him firmly. Not too heavy for your love. No, just you can hold it. You need one hand, yeah. Okay, let's yeah, but I want you just to zoom in there. Good. Okay. There. Finally, you notice that this is white and this is red. Yeah, this is white and this is red. Means that there is a fascia here. And that fascia is called, what fascia, Brittany? The lunate fascia. Okay? So the ishiorectal fossa is an area right around here surrounding the anal canal. Right? And that anal canal, so last says that it's wrongly named. It should be called not the ishiorectal fossa, but the ishioanal fossa. So this is the levator ani together with the coccygeus. And levator ani together with the coccygeus is equal to what? Pelvic diaphragm. So that ishiorectal fossa that may become a serious site of infection, right? Or a terrible infection here. From the anal canal, like an anal fissure, like a torn thing. Right? So I'm just going to tell you now, the good Lord made everything for a reason. Our eyes are made for a reason. The heart, the vagina is made for a reason. The anal canal is made for a reason, the rectum. So you young ladies, you be very careful of some of these men. You have nothing to do with them. Right? They must stay where they should be. And don't venture away from that area.
Oh,
Okay, that's it.
Very much needed.
Isn't it?